The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everybody. I'm Michael Flora with MTM Services, their Senior Operations and Management Consultant, and it's a pleasure to be with you today as we kick off another series in really our lessons of leadership. This is Leading Sustainable System Change, an example from Georgia. Joining me today is Monica Johnson from the state of Georgia. Monica and I will introduce ourselves here in a little bit, but wanted an opportunity to welcome you. Monica, if you could tell us a little about yourself and your background.
Sure. Thank you. Thank you, Michael. Glad to be here. Hello, everyone. Thank you for joining us. As Michael said, I'm Monica Johnson. I am here from the great state of Georgia. I am the former interim commissioner for the Department for Behavioral Health and Developmental Disabilities, and also the former division director for behavioral health at the same department, and former child and adolescent mental health director, same department. I have 26 years working in behavioral health. I'm a licensed professional counselor by trade, and very excited to share with you how we transformed our system here in Georgia today.
Thank you, Monica. I've had the pleasure of working with Monica and the team in Georgia for several years, and we'll highlight some of that transition over time from system change, dramatic system change, to all the way through CCBHC implementation. So sit back, relax, feel free to answer questions or ask questions via the chat. Our colleague Jody Gibney is here kind of fielding some of those questions for us. There will be an opportunity for questions at the end. But if you do have a question, please feel free to raise your hand or pop it into the chat, and we're happy to address it. So thank you, everybody. A pleasure to be with you, and let's get started. So as we think about leading sustainable system change, the first thing that came to mind when kind of putting this together was the tremendous work that Georgia has done and the work that Monica has done in helping lead that state. So let's take a look at our learning objectives for today. How to develop clear goals and objectives, understand the why and the how of system change. Flexibility, allow for learning and adjustments and adaptations in those true plan, do, study, act. Flexibility, our buy-in, knowing your customers, your stakeholders, your partners, your audience, and why they seek buy-in, what's important for them. Focus on persistence, adapting as needed. So we're going to talk about adaptive change as part of our work. Humility, being okay and seeking help to fill in knowledge gaps and learn from our mistakes. Communication, the importance of communication and planning in messaging, communication to stakeholders, peers, both internal and external communication. And then executing, arrive at the destination, being able to celebrate and monitor our work. As Monica developed a little bit of her work, but you can kind of see from her background, years of experience, but also leading I think the state of Georgia with compassion and professionalism to really help the organization move to rapid cycle change. And then my background with MTM Services as a licensed professional clinical counselor and their senior operations and management consultant and CCBHC lead. We know that the need for states to embrace, adapt, and change is more essential than ever as more certified community behavioral health clinics come online and the new 988 system becomes more utilized for individuals in crisis. States will need to develop the infrastructure and funding and methodologies to support their providers and meet the growing needs of demand in their communities. The Georgia Department of Behavioral Health and Developmental Disabilities and MTM Services is working very closely together on large-scale system changes currently being implemented on a statewide basis since 2014, and Monica will highlight some of that work. But let's take a look, and Monica, if you could join me, maybe looking at this transformational journey, beginning back to 2014. What are some things that kind of pop out to you in some of the things that we've done together?
Sure. I think it's important for the listeners to have some important context and background. Around 2014, the department had underwent some significant reorganization, and the behavioral health division was formed. That division encompasses every part of behavioral health systems that you can think of, including both mental health and addiction services, both children and adult mental health services, crisis services, housing, housing support services, a plethora of activity under the behavioral health umbrella. So it was a lot to absorb. And what we took the time to do, and this was before CCBHC was what it is now, we wanted to do a couple of things to transform the way our network provided business. So in Georgia, behavioral health services currently are provided through a network of contracted providers. And I know that different states do this differently. Some have heavier managed care presence than Georgia does as of today. But at that time, we needed to really do some system work in our provider network. Our provider network consisted of public entities. In some states, they're called community service boards. It also consisted of private and public for-profit organizations. And so with that wide plethora of types of providers, we really wanted to raise the bar around expectations that we had, because we were in a huge moment of transformation. Georgia is sometimes referred to, I don't know if this is a good thing or a bad thing, but referred to as one of the initial states that was sued by the Department of Justice for having individuals and institutions too long. And so we were also in the middle of building up community capacity to serve individuals in the community that just historically had not been served in the community. So that background is important of why we wanted to make sure that the community system was ready and prepared to meet a level of standard of care that was beyond average, above average, and it required a lot of system design. And so with that context in mind, we partnered with MTM. We needed some help in looking at our system and comparing where we were in Georgia with other states across the country. And so the work really began to look at, yes, how do we meet the deliverables that are in our settlement agreement, which again fundamentally required us to build up community capacity for individuals with serious persistent mental illness. So building up that capacity, which really was a lot of high-end crisis-oriented services, and it didn't really speak to what I call the core of the network, which is your traditional outpatient type services, rather that's therapy, case management, some peer work, etc. And so we wanted to make sure that the foundation was solid, because you can build a system, but it cannot be built on crisis alone, and it cannot be built on just your high-end services. And so what are the upstream services that need to be built, and how do we monitor that system for accountability, make sure that the quality was in place? And so we did that. We underwent a pretty significant system redesign. One of the highlights of that redesign was the development of standards and key performance indicators that the department still uses to this day. So just a little contextual history there to kick us off. Michael, I'll turn it back over to you.
Thank you, Monica. And also, as part of that, what we did was some community assessments. So we looked at some systems learning opportunities, some learning communities with the provider network, but we started at the state level, right, Monica? Really kind of doing that core redesign, that level setting, and then the community assessments. And then what was also happening about the same time that CCBHC was beginning to develop with the demonstrations nationally, Georgia was also undergoing a change in the way they funded service, from grant in aid services to fee for service. So as part of the core redesign, also helping the provider network and the state navigate and move to fee for service readiness, which then created system support. And as Monica said, there's various tiers in the public safety net providers, but also what they call tier 1, which is the safety net providers, and then tier 2 and specialty providers. So at that point, between 2016 and 2017, now the tier two providers had already had fee for service. That was part of their contracts. But the community service boards had not. They were getting grant funded. So that was a major shift in the way they were funding. So move from grant funding to fee for service. So getting them ready. And I remember at the time, even many of the providers were saying, why can't we just jump to this prospective payment or value-based payment right away? And I remember having conversations with leadership and providers across the state. It's like, we need baby steps to get there. We need the competencies, we need the business acumen to really understand our costs by CPT, HCPC, and provider type, to really understand the level of care needed by level of care benefit design. And then around 2019, we began looking at that CCBHC implementation, really getting the system ready. And that included both state and provider CCBHC readiness assessments. We assessed the community service boards in their readiness to meet the CCBHC requirements, but also at the same time working with the state. How is the state ready to meet the certification requirements based on some proprietary tools that we've developed? With that, we also then began the system design and planning. The system design and planning was a series of, at least the first year after the assessments and the readiness work, is learning communities for the providers in the state, but then also some structural committee work at the state level, and then expanding that later to even where they're at today with a system of need and demonstration funding. And maybe Monique, you can talk a little bit about that and where you're at today with some of that funding as we've moved from the core redesign all the way through to today with the CCBH expansion in your state.
Yeah, so we're still in the fee-for-service implementation here. The department is still in the fee-for-service implementation phase. And what's happening is CCBHC is going to end up being the bridge that helps move from fee-for-service. I don't want anybody on the call to think that we believe that fee-for-service was the thing to do and the place to stay. It was a step in a process. Painful process at times, but it was a part of a longer term vision so that we could better understand the costs. And the pronoun we was used intentionally. So we, the department, and then we, the providers, to better understand the true cost of services, moving out of a much more dated system, which was a grant and aid type of a system. So I think that system continues to transform, but it is definitely way further along than it was when we first made this transition in Georgia.
Absolutely. And so when we think about kind of where the vision was, that we understood that healthcare reform has created a tremendous amount of disruption in all aspects of healthcare. As many states and communities have witnessed increase in demand, individuals seeking services to meet their needs, to meet that safety net in a time when even more recently having more staffing challenges. So this tremendous growth in consumers and managed care and alternative payment methodologies has put overwhelming pressure on states and providers in those states to provide high quality services customized to the individual while maintaining financial and operational practices that are in compliance with insurance, billing, and federal and state and local requirements. So think about this. In the current landscape, will your state and provider organizations be ready with internal utilization management, corporate compliance, credentialing, risk management, authorizations, claim submission to really take advantage of increased opportunities for revenue under Medicaid managed care, alternative payment methodologies, CCBHC, and other value-based environments? So what will we need to do from where we are now to where we want to be, which is really what you saw in the vision back with core redesign all the way through, as Monica said, fee for service was a step moving towards that work. When you really think about where we're at with CCBHC now, we're well over 500, I think, CCBHCs at this point across the many states that we're working with. And so when you think about states and clinics receive the expansion grants, or the orange, the striped, or those that are in the part of the original demonstration, and those that are currently working on independent statewide implementation. And so what we've found over the years is just kind of moving in this direction as alternative payment methodologies is a step. But then also the role of 988 and crisis intervention. I know that was always part of the overall work, especially as the state of Georgia moved to 988, and how that was braided, correct, Monica, in with the CCBHC and how they go hand in hand.
Right. We definitely see them as cousins. And so, because again, you can't just talk about what happens when the individual's in crisis. I think CCBHC is one of many options that really pairs well with what happens after and before a call is made to 988. So yeah, absolutely concur.
Mhm. And so when we think about transformational change, it's really about the ability of leaders to create an inspiring vision for the future, motivate the provider organizations and community stakeholders to achieve that vision, manage implementation successfully, and develop the members and their teams to even more efficient and effective use of the future. So we explore these dimensions, and the key element here is the ability to create a robust and compelling vision of that future, and to present this vision in a way that inspires others, not to just develop, but actually implement the needed changes, follow through, and develop the ability to monitor. So when we talked about policies, procedures, uh, key performance indicators, developing the performance management responsibilities for both the state and the providers, that has served, I think, Georgia well, and really looking at that. So a lot of this is planning and decision-making side of change. So when we think about the way we make decisions as provider organizations or even at the state level, it's the processes of change. How do we put project teams in place to do this work? Measurement of the current delivery system. What's our baseline now? And what's the gap between where we are to where we want to be? And developing those performance standards to shape the system for the future. And organizational and management structure realignment, what will that look like? Developing the standardized protocols, what is it that we expect? And then inspecting what we expect. And then using the data to show not just the subjective, the anecdotal, but we've seen changes in deltas in functionality. We've seen increases in individuals served. Because sequential change, which is what we're all used to, is completing one goal at a time. Sequential change is horizontal. But transformational change, Monica, is continuous quality improvement. Transformational change is vertical, because in the work that you did, a lot of that was very interdependent on one another, wasn't it?
Correct. Absolutely. And we don't have I think this won't sound foreign to people that in most instances, we don't have the pleasure or the flexibility of time. And so having to make rapid changes that are complex cannot necessarily be sequential. You have to do some things parallel in order to get the change or the transformation that you're seeking to happen. And I'll say a little bit more about that later, but I just think it's important to distinguish between the two, and just understanding that in most of our environments, if you really want to do transformational change, you're going to have to be able to walk and chew gum at the same time, and have goals that are parallel to one another.
And I think also juggle. Talk a little bit, Monica, about the overall system change goals that you developed.
Sure. So one of the things we wanted to be able to do was develop more accountability within our community-based behavioral health network. When I talk about accountability, again, when you hear me say the words "we," and I'm a former employee of the department, and so when you hear me say "we," what I'm talking about is at the state level. So at that time, at the department, we had some work that we had to do, and so I think taking an honest reflection of the mirror and being very transparent and honest about what your strengths are as a state agency and what your weaknesses are, and not being uncomfortable. You can be a little uncomfortable, but not letting that block you from leaning into the weaknesses or the deficiencies that you find. So accountability runs throughout the system. So at the state level, and then also in the provider network, Because at the end of the day, the common goal should be we want people to have easy access to high quality care, period. All right. So if that's the goal, how do you make sure that you can measure, that you have data to support what is actually working and what's not? That's accountability. But everybody has to be on the same page. People have to know what the expectations are. People have to know how will they, what will be the data that will be collected? What are you going to do with it? Does it go into a black hole? Do you actually report back out that information and use it to continue to drive the ongoing transformational change? So that piece is important, the accountability. The second component that was really critical for us was preparing the network for fundamental shift. So again, you heard me talk about the heavy utilization of institutionalization in our state, and psychiatric hospitals are still a part of the continuum of care, as I think they should be. It's a part of a system. But we did a drastic shift from the level of state hospitalizations that we did in Georgia to really redirecting individuals to community-based treatment for both mental health and substance use disorders. And so preparing the network means training that network. It is not meant to be a pop quiz. It is, here is what's needed to make things happen, and here is why, making sure people understand the why. But giving providers, giving state workers, giving whoever is needed to impact the system, giving people the tools that they need in order to make the shifts that you're expecting. Collecting useful data elements. I find that in many places, I have colleagues across the state, and most things aren't that different state to state. We all collect a lot of information. I think we could do a contest on who collects the most information. The winning person wouldn't win by the quantity of data that they collect. It would be about the quality of the data. Is the data useful? Is it accurate information? Is it reflective of what you thought it would be? And if it's not, do you make adjustments, or do you just keep collecting the same information because that's what you're used to doing? So making sure that you're not only collecting data that can inform, from my perspective, at a state level, but then also at a provider level, at a community level, at a county level, and all the way down to an individual. So we should be able to know along the way at each point in the system what's working, what's not, and the data should drive that. Data will not drive it if it's junk data, if it's not meaningful data, and we don't adapt over time to make it be useful to inform the system. And then use that as a communication tool as well. This work, unbeknownst to us, laid the foundation for the future, which is now, which is CCBHCs. And so getting the network more accountable, having more community-based treatment in place, doing all the things, the culture shifts that come with that type of shift to building out a robust community-based system, and the data that goes with that, laid the foundation to where we are now. That's transformational change. And it took literally about a decade's worth of work. And then, of course, providing technical assistance for the network to achieve any of the goals that you lay out. For every goal, for every expectation that we set forward over that 10-year period of time, we provided technical assistance. So we're going to tell you, this is what we want to do. This is why we want to do it. This is how we believe we want to do it. We're going to get input. We're going to do all those things, but then we're going to give you the tools, the training, and the support in order to be successful. Again, this isn't a pop quiz. So we want you to have the answers in advance. So making sure that you support the provider system, you support that network, because they're leaning on state systems, because that's the perspective I'm using today. They're leaning on state systems to help them be to accomplish their goals as well. Next slide, please.
And I think that's a good good segue, Monica, because I think, I like that it's not a pop quiz. That here are the answers to the quiz, here's how we can help you. And that's the difference between the old way and the new way. So the types of change we want to address, and I think that was one of the things we looked at earlier, is what is a technical change and what is an adaptive change. When we think about adaptive leadership, adaptive change recognizes there's two types of change, technical and adaptive. Technical problems is a kind of a satisfactory predetermined response, right? The problem is very clear and the solution is very clear. That's technical. Adaptive problems are those that we're not really trained in to really see. In most cases, the definition of the problem is very vague. There aren't as technical fixes that we want to think about. So such as individual first helps to define the problem and then mobilizes the coworkers to come up with possible answers. So adaptive change requires learning, which is really what Monica's talking about preparing the system for change. And the adaptive leadership approach views leaderships more as a process than a set of competencies. Having said this, when we think about the skills, adaptive leadership, adaptive organizations, adaptive transformational change needs to be able to connect organizational change to the core values, the core redesign, the goal, the why, the capabilities, the dreams of the relevant stakeholders. What do we hope this system to be as we align the future? The adaptive leader seeks to foster a culture that collects and honors the diversity of opinion and uses this collective knowledge for the good of the organization and the community stakeholders. The adaptive leader knows that change and learning can be painful for people and is able to anticipate and counteract any reluctant behavior relative to that pain. To think that transformational change is painless is a false assumption. We know that change can be messy. So we understand that large-scale change is incremental process and that we're persistent and willing to withstand those pressures and not take shortcuts. Don't blink when we need to make the change. When we think about the Georgia plan, Monica, it truly was a plan, do, study, act with 3 distinct phases. Can you go over those for us?
Sure, absolutely. So phase 1 was really internal kind of look, like I said, starting with yourselves. And again, I'm thinking about this from a state level official type of perspective. And so we really wanted to look at our level of readiness at a state level, and being able to then lean into what is it that the providers would need. And so what was, and again, we're now at a point where we were moving towards CCBHC implementation. And so with that in mind, we first wanted to assess the readiness, again, not just of the state, but also of the providers. And you can see here some of the things that we looked at. But these were things, so when I look at electronic health records, access to care, some of these initiatives were things that we had been previously preparing the network through the implementation of some standards that were, I hate to use the same word, but the same set of standards for each of the providers, the same set of key performance indicators. And so some of that pre-work, I think, led to some of the providers having a better level of readiness. So that was our phase 1 work, and that took several months to complete. Phase 2 moved into the learnings. And so based off of what we learned from the readiness assessments that MTM as our consulting partner led for us, we were able to identify where the learnings needed to happen. And so from there, we developed a curriculum and provided that MTM led, but worked with our providers through pretty much what we deemed as a learning community that really targeted specific things that either A, appeared as deficits in the systems, or B, the providers just simply said, we want to know more about this, fill in the blank. And then phase 3 really began to move towards implementation. We're still the state is still in that phase, but you can see some of the specific steps and some of the specific deliverables that came out of each of the phases. But phase 3 is pretty much where Georgia is now. But I really just want to underscore, we were able to get to a phase 1, phase 2, phase 3, because of the investments made in really doing the work, which was not always like gleeful work, right? We're talking about a decade worth of work, that you have change in leaderships, you have change in commissioners, you have change in provider CEOs and CFOs. There's a lot of change that happens while you're still trying to move forward with this big transformative change. And so I don't want that message to be lost to those participating today, that the commitment to the process is not always sunshine, and sometimes it feels painful, but the end result for us has really put the state of Georgia in a different place than I think we would have been had we not made the investments and did some of the early work and stuck to it.
I think that's, and when we think about that early work, this is kind of a sample transformational change structure that we work with states, similar to what we did with Georgia. So we set up a steering committee, and we even did this back in 2014. We set up a very similar structure to really divide the work. So what's the organizational structure? What's the work team structure? What's the team of stakeholders, providers, state level officials that need to be part of this? So when we think about what we did at the state level for the CCBHC implementation, is we had the steering committee, which was made up of senior leaders of the organization, of the state, including the commissioner, chief financial operations folks. And then we had a strategic operations planning, which was then the director level folks that were part of, kind of let's make sure we've got this moving in the right direction from a strategic lens. And then the work teams underneath. So this could be, fill in the work team. So the first team was our finance and alternative payment methodologies, quality, compliance, outcomes and reporting, organizational authority, network adequacy, accessibility and availability of services, and then including stakeholders, and then demonstration leadership committees. And then, as Monica said, the kind of that state level kind of learning community. What does that look like? And again, around, you can see where the alignment. So as we start developing core redesign and implementation strategies and guidance, being able to provide an opportunity for systems learning at the provider level, similar to, what's the core concepts, and then where is the state going with these initiatives? What do we have in mind? So again, it's not a pop quiz, as Monica said. It's very transparent in the process. But I think the first thing you need to do in any kind of transformational change is you need to define where you want to go and get to team. Develop your organizational structure. And I think Monica and the team were able to put together some of those key objectives to successful change. You want to talk a little bit about those, Monica?
Sure, and I think these have stood the test of time. And so when I think back to these, they stood the test of time. And so I think these are important. It's not even an all exhaustive list, but again, assessing the existing knowledge base and determine if additional expertise is required. I would not have agreed to do this webinar with MTM today if I did not really believe in this first bullet. It's a starting point, and I think just recognizing where your knowledge ends and where somebody else, another entity, can come in and help bring some additional resources or additional expertise, not being afraid of that. Sometimes MTM consultants would say things to us that we'd be like, huh? And then later on we'd be like, oh, okay, that did make sense. We needed somebody else that was kind of, for lack of a better way to say it, foreign to our system, to look back at us and help us be the reflection in the mirror. So I think that honest assessment around what are the gaps is important. And that's not easy for people in leadership roles to sometimes do. You're expected to know the answers, but sometimes the answer is, I think I need help, and that's okay. Making sure that you obtain buy-in internally and externally ASAP. For any change initiative, you can fill in the blank with any topic. If you don't have the buy-in of your internal team members, your external stakeholders, it's going to fall apart. And so people really need to have clarity around what is the problem we're trying to solve? Why are we trying to solve it? how do we plan to solve it, and what do we expect to be outcome as a result of this work we're about to embark on. So being clear about those things and being able to communicate it often, clearly, and then again, as many times as needed is really, really critical. But if you don't get the buy-in, you're kind of dead upon arrival. So taking the time to get the buy-in, and knowing the sweet spot of when do you reach out to your external stakeholders to get buy-in. And this is important because there is a sweet spot. You don't want to do it too early where you're still trying to clean your own house and figure out where are those gaps. So going back to number one, right? So if you're in the assessment period, sometimes it's too early to put out a blank sheet of paper and say, hey, we know we need to change. Here's a blank sheet of paper. Everybody tell us what we need to change. There needs to be some guidance and some clarity around what is the purpose of what we're doing. And so timing that external buy-in, I think, is important. Making sure that you bridge together a diverse team of subject matter experts, and be sure to include those that are most skeptical about the change you want to make. And that is important. If you just have people around you that are going to disagree with you, rather it's because of the role you have, the position, whatever it may be, then that's not going to be helpful for you. So you need to have the people who are probably going to be your biggest critics, that have the most skepticism about the project or the initiative. That's really important, to have those individuals lean into the work. You will learn things that you didn't know and that you needed to know. Be adaptable and accommodate when needed, but stay the course. So MTM would say to us often, like, don't blink. There are going to be things that happen that are going to make you say, yep, never mind. We could just go back to the way we were doing it before. It may not have been the best way, but it's the easier way, right? And so that stayed with me personally for the last decade, is understand where you're trying to go. This is not about being rigid. It is about staying the course to get to the end, but you know you can change your play, right? You can change the plays up. So you don't have to stick to a play that's not working. You can change the play. It doesn't mean you're still not trying to get to the end zone. So staying the course, but accommodating and being adaptable as you need to. I cannot emphasize enough, you've heard us say it several times now, but training, educating, technical assistance, support. This is not about, aha, I got you. This is about how do we collectively make our system be what we want it to be for the people that need us the most. Assess your milestones, examine the progress, and modify based on your findings and the data. So when Michael talked about earlier, the difference between transformative change and then change that basically is we'll wait till we get this goal, and then we'll do the next thing, and then we'll do the next thing. Not going to be able to do that with a real big system change. You're going to have to do the stuff parallel. And so thinking about that and thinking about this bullet, the last bullet here, you have to create milestones to celebrate, so you don't lose momentum. So you don't have to wait till every goal is completed. It doesn't have to be, again, in a sequential order, but make sure that you celebrate milestones as they occur. And that helps keep people motivated. It helps keep people's eyes on the goal, on the prize, whatever it is you want to say there. But you got to be able to celebrate along the way and count your wins. And when you have a loss, because something will not go right, something will not happen the way your perfect plan came together, that you can appreciate that moment too, and you can celebrate the learning that you got from that experience as well.
Well said. And see, when we think about kind of assessing the milestones, and that's the whole plan, do, study, act, and putting that. So what's our plan, and then implementing. Many times with provider organizations, we get to a point, Monica, where we get to that edge, and provider organizations might blink, especially with long-term change or even systemic change to make it possible. So whatever those blinking opportunities are, I think using those opportunities, even if it didn't go right. So if it doesn't go right, that's the plan to study. So the study tells us, all right, so it didn't go quite right this, or where did we miss the mark? But not that we're not heading, you're absolutely right, to get to the goal, to get to the outcome, because we use what we call that scramble team methodology. Let's put some folks together in a room and figure out why this didn't go right the first time as planned.
Mhm.
What we're going to execute a new plan to still move towards the goal, because that leads us to the outcomes.
So a decade's worth of work. And when I say that out loud, it sounds completely unbelievable to me. But I mean, if you want to talk about transformational change, we are the people to be talking to you about this, because I was there from the beginning. I only recently left the department. You'll see me pop up somewhere else later. Stay tuned. But I think that having time to reflect I've been on a sabbatical for the last couple of days. And so having time to reflect on the work, and this is one of the pieces of work that I will always keep with me, because it has long lasting outcomes, and it doesn't matter what person is in the seat. And so here are some things I just wanted to share upon reflection. So we did all of that work. We did all this transformation. I could have done a full day seminar on, so tell me all the things that happened as a result. We don't have time for that today. So I tried to put them in a couple of buckets here for us to absorb. But this seems so simple, but it's a really big deal. Cementing the work that you do. And so again, I'm talking about from a state level, but this is applicable, I think, at any, with any organization. We developed a series of policies that really cemented a lot of the work that you heard us talk about. If you're interested, you can go to DBHDD's website. You can Google Georgia DBHDD, Department Behavioral Health, Developmental Disabilities. And on the home page, there is a About Us tab, and then there's a policy link. It takes you to a platform to get to the state organization's policies. And there's a search button. You can type in the number 01200 that is here, and you can see for yourself the policies that were put in place that really formulated a lot of the transformative work. And if you're a CCBHC buff, what you will also see, if you put in CCBHC as a search, that there's a policy now around standards and expectations for our CCBHC demonstration sites here in Georgia. And so cementing the work in policy. But I want to say something special about the word policy here. I don't mean policy that nobody ever looks at. And I don't mean policy that nobody ever revises. So we were very intentional about making sure that these policies are reviewed on an annual basis, in which that will continue to happen. They expire on an annual basis to force somebody to look at, are these still the right policies? Every year, like clockwork, the data that is collected from our provider network, which is now done through a web portal that was built by our IT team at the department, where providers now go in and enter information around data like your no-show rates, how do you interface with someone coming to you for crisis, how quickly does it take for somebody to get an appointment? These are things that used to be on an Excel spreadsheet, and we used to try to get providers to fill that in. Now there's a web portal, and some of that data is pre-populated because we have a way to collect that data on our own. So policy is not just a word, it's an action. And if it's not an action, your policy is not that great if it's not actionable. So that's just really important. Clarity around the role of the different types of providers. This was important for Georgia. It may not be important for every state, but for Georgia, there was confusion about who did what and why and when. And so clarifying this is the type of provider you are. You fall under this tier. You heard Michael reference our system here, tier 1, tier 2, tier 3. That role clarity, as simple as it seemed at the time, had huge benefits, and it still exists to this day. You heard me talk about the web-based portal, which I'm very proud of. Every year, a team is not just the staff from the behavioral health division. It's people from the compliance team. It's people from the data management team. It's people from the quality improvement team come together every year. And before COVID, we would go do this in person. Now we do it virtually. We've stuck with it because it's just easy access. But every year we talk about this policy work. We talk about the expectations. We talk about what the key performance indicators are for the year. We talk about what the data was for the previous year. So providers would sometimes say, we think that this particular standard is too stringent. But then the data will show that 92% of the providers are passing it with no problem. It's like a B or higher. So using the data to actually inform perception and reality is important. And we do that on an annual basis to keep it alive, because remember, policy is not to be put away on a bookshelf with dust nobody looks at. So you got to have a way to keep the work alive. Obviously, outcome clearly was the readiness for transition to CCBHC. Georgia has, I think, about 10 demonstration sites. We have been very creative in how we have funded them. Some of those CCBHC sites are funded through, obviously, the SAMHSA grants. Others are funded through we did a couple demonstration ones through some block grant dollars. And then we were able to get the state legislature to appropriate state funds for 2 demonstration sites. So we have a triad model here in Georgia. And so that readiness work, though, allowed us to be able to do that. Making sure that the data provides a measurable way to access care. We have been able to give information to legislators, give information to the governor's office when they're asking questions about the network and the system. We actually have data that can tell us a lot of information about our system that we did not have 10 years ago. One of the really cool items that we have that is not necessarily loved, but I like it, is stakeholder perception. It's a survey that our providers are required to give to key partners. They select them. Key partners like sheriffs, emergency department, supervisors, schools, etc., to tell us, what is your experience like working with this provider? So we get a lot of information, but it's useful information that tells us how our system is performing, for the good or bad. We know how it's performing in a systematic way. It provides consistent measurements that can be used to describe our network in multiple ways, and then relevant quality improvement initiatives that are based on the performance of what we see. So when we see there's some deficits, we know what we need to focus on in terms of rolling out quality improvement initiatives. We don't want anybody to fail. We want everybody to be successful, because that is how we get to good client outcome and good client quality care. So we do whatever we can to help support when we see that there are deficits in the system. So this is a very abbreviated list of some of the immeasurable outcomes that have come out of an initial phone call or email that came about probably in 2013 from the department to MTM to say, I think I need some help here. And so this is what transformational change can look like. From a leadership perspective, I think that this has been one of the most impactful things that I've done in the role I've had in state government.
And I think when you think about kind of the transformational piece, and transformational, I think even as a leader, wouldn't you say, Monica? I know that kind of as leaders, when we lead organizations, when we assist organizations in making that leap to the future, we learn lessons as well. And what are some of those lessons at the state and that you found?
Sure, absolutely. Develop processes that are not person specific or and are sustainable. People are going to leave. People are going to change roles. You're going to have musical chairs happening. That should not make or break your systematic changes if you have done them in a way where they're not specific or tied to a person. Remembering to celebrate the milestones, a system change can take many, many years, and in this case, a minimum of a decade. Be transparent about your why all the time and be transparent about your data. Collaboration and accountability can and they do go together. Develop space for learning to occur that is not punitive. Correct mistakes and take ownership. There is nothing wrong with, for me, it's one of the best things that could happen if a provider says to me, hey, this policy, whatever, it's not working, this is why. Or it's just something that was a bad idea to say, you're right, we didn't think about that. We need to correct that. Take ownership for that and correct it and move forward. Listen to your stakeholders, find opportunities to do that as often and as reasonable as possible. Take the time to make sure that any data that is collected is valid. And then find, again, mechanisms to keep the change active versus passive, as I referenced, related to the road shows. Like, it could be anything, but find ways to keep your change active. There's always something new to learn. There is no end date, right? This is an ongoing complex system that is forever evolving. So finding ways to keep the change that is always going to be present active and keep people passionate about it.
I think that's very well said, is that this is a continuous project, a continuous process of change and evolution. As payer methodologies change, as there's change in leadership, as there's change in demand, change in the way we deliver service, creating that sense of urgency. Think about, within, 2 years ago when we shifted an entire system of care across the entire country from face-to-face interventions to telehealth. And now what does that look like now, even at the state level? As we see more providers, I mean, a lot of research shows that individuals served welcome and find that telehealth is valuable. We know that the workforce is there and looking at that. So you think about the change will always happen. As they say, the only thing that we can expect change, with the exception of coming out of a vending machine. So that's what we want to change, is we want to expect change in our systems of care. I think we're at a point, Monica, where we can kind of open it up for a few questions.
I agree.
Feel free to put some questions in the chat, team, if you have any of those, or raise your hand. Happy to call on you if you have any questions of Monica or I about the process. But also want to acknowledge all the hard work that the state of Georgia put into place, all the caring professionals at the Georgia Department of Behavioral Health and Developmental Disabilities, as well as the provider network and the systems, the individuals that a lot of this change positively impacted. So really thanking and acknowledging their work as well. What questions do you have of us? I can ask maybe, Monica, one question of you. When you think about the one thing that sort of makes you smile about this work, what would you tell us that would be?
So that's a good question. I smiled immediately, right? So I think that for me, and it's going to seem cheesy to people, but it's the truth that we literally, it started so long ago, literally a decade ago, with what felt like a simple, small idea around, we want to figure out how to make the system be better. I had no clue that transformation could look like what it looks like now. And I referenced, earlier, I mean, like I recently, I'm in the middle of a transition. And so I've had time to reflect around what or the things that feel like legacy products to me. And this is one of them. But I had no clue that just leaning in and asking a couple of questions would lead to the level of transformation that we've had alongside, I mean, there's no doubt about it, alongside the expertise that you guys brought to us and the consistency in that over the years, over a decade. So that makes me smile.
Well, we've valued your partnership, and we've learned a lot along the way together. I think really how resilient the system is, how adaptive the system can be to really embrace transformational change to really help individuals, which is really why we're in this business together.
Yeah, and I think that, like we said, healthcare is so evolving. Behavioral healthcare is everybody's topic du jour right now, which is good. I'm excited about that. But what I do know is that the system, while it still has work, no system has reached a level of perfection. There's still work. There's still things on a wish list that I'm sure that we still would have here in the state. But I feel like that work has made it easier for somebody to access
Hmm.
behavioral health services. And that's what it's all about at the end of the day.
What advice would you give our other state partners on the call today?
I think that it's, again, probably going to sound cheesy, but I mean, this is the reality of what it felt like is you have to have a vision and you have to be bold. And I think that people tend to believe that if you work in state government, you cannot be positively bold. And you can be. And I think that you can ask questions. You can say, but why? Because we just do it that way, but why? And I think leaning in with curiosity is important. And I just think that I never thought when I was figuring out what I want to be when I grew up, this was not it. I did not think I would be working in government. That's not what I thought. Thought I'd be in private practice somewhere, not taking insurance. But this is where my path led me here, very specifically here. And I was able to be a part of a team that made a difference. And people said, if you go into state government, you will die on the vine. Somebody told me that. And so I think that that is not true, but you got to be able to be bold, but be smart. Like, don't be out here and be reckless. I'm not telling people that, but be
Mhm.
bold, be smart, be purposeful, and just have vision. And I think that to me is really important.
Well, I want to thank you today for your leadership over the years, your partnership over the years, Monica, but your compassionate leadership, and I think your voice that lended itself to change an entire system of care. So I want to thank you for that. Your innovative and compassionate leadership, and helping us, really understand the necessary needed changes for transformational change. With that,
Thank you,
team, I
Mike.
want to thank everybody for your time and attention today, and we look forward to hearing about your future successes as we go forward. Thank you, Monica. Have a great day. Thank you, everybody.
Thank you.